Good morning, everyone, and thank you for joining us here on the Nebraska Medicine Facebook page. My name is Kayla Thomas, and for the third straight year in a row, we're sending kids back to school in our community with COVID cases active. And that's certainly not the only health concern going around in our area right now, with monkeypox circulating around the nation. And of course, the news last week of the first ever death in the state of Nebraska attributed to a brain-eating amoeba. We know that you have questions about all of these topics. So today we have asked one of our experts to jump on and give us the latest information on all of these topics. Dr. Kelly Cawcutt is back. She is an infectious disease expert and a critical care physician as well. Dr. Cawcutt, thank you for your time and your expertise as always.
Always happy to be here.
All right, I've got a big list of questions for you, but first, for those of you watching, just a reminder, this is a live chat for informational purposes only. So if you have any questions specific to your own health or medical condition, please direct those towards your primary care provider. So Dr. Cawcutt, let's start with the case last week of that brain-eating amoeba. The first time we've ever had anything like this happen in the state of Nebraska, though there was also a recent case in Iowa. Still time left, still Labor Day, and lots of boating and swimming going on. Is this something people will need to be concerned about?
Yeah, so that's a great question. And it is certainly concerning to have seen two cases so close to us, just over the border in Iowa, and then our recent case here from, really attributed likely to the Elkhorn River. And so this is an amoeba, Nalgeria fowleri, which is well known to cause infections amongst people who have been swimming in fresh water. However, those infections have been incredibly rare. So if you look at the CDC's website from 1967 or so through the end of 2021, the US had really only seen 154 cases. Now, the downside of this is that it is a severe infection where 97% or higher of people who've been infected had died. There's only been 4 survivors in the United States spread over that period of time. And, we do see millions of water exposures every year to freshwater exposures, but there are certain scenarios in which the risk of this infection goes up. So first, the primary way people get this infection is getting freshwater up through their nose. So not submerging your head under fresh water, using nose plugs or the goggles that have the nose piece in freshwater lakes are some of the things that people do consider, and people who have been aware of this amoeba have actually been considering in freshwater regardless. The reason people are more concerned right now, obviously having seen a case of this, is, well, how common is it? How much risk do I have? Why did we see it now? And there's a few things that are important to understand. This amoeba is very common in freshwater, to the point that it's not even recommended that people are routinely testing rivers and lakes and things like that anymore. But there are circumstances in which we see a lot of growth. So really warm weather. This amoeba thrives in hot summer days. It loves temperatures of 100 degrees or more. And it also seems to be more concentrated, as one could imagine, when we have less rain and we're seeing lower water levels, more drought-like conditions. And it does also seem to kind of really flush up with sediment in the bottom of the freshwater area and lake. So we've had a lot of hot weather. We have not had a lot of rain, and a lot of the lakes and streams, and freshwater sources in our area have gone down in their water level. And all of those really can make it a perfect scenario potentially for this particular amoeba going up someone's nose and causing the infection. So I think for those who are going into freshwater, it's something that you have to think about and consider. And as temperatures fall and water temperatures fall, the risks again start to fall. Now, we've only had one case here, again, only 154 from 1967 to 2021. So yes, it's a concern. Yes, people should be thoughtful about that and may want to change some of their water exposure habits, especially in this time of the year when it is so hot. But the overall risk to people in general is going to remain low, as it has for the last many years.
Just a quick reminder to those of you who are watching us live, if you do have questions for Dr. Cawcutt, you can go ahead and put those in the comment section. We will get to some of those if we can. We do have a list that have been coming in through our website related to all the topics we're discussing today. We'll later get to monkeypox and to COVID as well. That number that you mentioned, that 97% of cases being deadly, is pretty stunning. What are the symptoms of this and how can you treat it? Can it be treated?
Yeah, so there's once you have a water exposure with kind of that forced water up the nose, there is that potential risk, right, of this amoeba potentially getting there. Now, people start to notice headaches, nausea, not feeling well, and eventually develop fever and altered mental status. And a lot of patients, the diagnosis is delayed before people realize what the cause of this brain infection is. The average, or I should say the median time, so the most common number of days from time of exposure to presentation is about 5, although it can extend for between 1 to 2 weeks before people present with symptoms. And again, once you start with those symptoms, we do see progression to more neurologic symptoms, more altered mental status when people come to the hospital, really kind of like a meningitis that you would think about people presenting with. As far as treatment, there are many medications that are used to treat this infection, but again, the mortality has been extraordinarily high. So even though treatment is available and would be administered with the diagnosis, there's no guarantee that that treatment is curative. And that's really where the risk lies when we think about water exposures and something that is preventable by avoiding, water getting kind of flushed up a nose.
You mentioned that this has been seen before more commonly, although it's not very common at all, but more to the south.
Yes.
With climate conditions changing, temperatures being warmer, is this something that we could see more of as the years go by and things get hotter?
Yeah, I think that's a great question. And I think the answer is probably yes. We know that temperature matters to this amoeba, especially in, again, warmer, freshwater, higher drought seasons. And we've seen that impact of climate change and increased warming and kind of longer, hotter summers in some ways from that perspective. And so absolutely, could we see more of it? The reality is yes. Now, it has been seen in states north of us. Minnesota has had cases of this in their lakes also. Now, again, I believe they've only had 2 cases that I'm aware of to date, as of at least through 2021. But it has been seen as high as Minnesota. So yes, could we see more? We absolutely can. What we don't really have the best understanding of is why, when there are millions of water exposures, the numbers are so low. And, are there some capacity for certain people where there's an increased risk, or is it really just kind of an episode of very bad luck in warm water with a lot of the organism and a really kind of forceful nose full of this water? Drinking the water, so people who accidentally swallow water, is not a way that you get this. And so it really does have to go through the nose in order to enter the brain. And I think that's the biggest thing to consider. There are certainly people who work in the healthcare community who do not swim in fresh water or do not put their head below fresh water or are only wearing nose clips in those scenarios to try to minimize this risk, especially historically when they've traveled to more southern states where the risk is higher.
Thank you for all the information on that. I think we've all learned a lot in the last week or so on that topic. So still more questions to come, and we'll continue to consult our experts. But for now, let's go ahead and slide on to another topic, monkeypox. What are we currently seeing in our area in regards to monkeypox cases?
So we are seeing, I think, what we've seen in many communities, which is kind of a slow and continual rise in the number of cases. As of yesterday morning, we had 17 confirmed cases, per Douglas County. We have many patients who have been evaluated and tested for monkeypox for those rashes. But I do think we are expecting at this point to likely continue to see more cases, at least for a period of time, if not something that might actually become endemic, meaning we may see this virus staying in circulation in our community if we continue to have this kind of slow perpetual rise. The patients, thankfully, all have had, for the most part, very mild disease. When you look at the data nationally and globally, compared to historical monkeypox outbreaks, we're not seeing that disseminated deadly disease of monkeypox, but we tend to see patients with, just a few smaller lesions, not getting as sick, not necessarily needing to be in the hospital at all because of those symptoms. So really much more of an outpatient evaluation, or patients who've come into the emergency room with a new rash, concerned about whether or not they may have this. I do think it is important to note that this can spread to anyone. So children, adults, it can be spread from anyone that you have close contact with who has active lesions. So I know there had been some concern about which populations really are at risk, and anyone with close contact is essentially at risk if you have contact with someone with monkeypox.
We've heard about skin to skin transmission. What are some other ways that it could be transmitted?
So right now it is primarily skin to skin contact that is, prolonged, meaning close contact that is lasting, for minutes, things like that. In more severe cases, if people had oral lesions or airway lesions, yes, they could cough the virus out. Yes, you could see it from saliva, mucous membrane spreading, but that's really not the mode of transmission we're seeing right now. It really is primarily skin to skin contact, which can include skin to skin via sexual contact, which I do think is important to recognize.
There is a vaccine. So is it being administered now? And if so, who should be getting it?
Yeah, so it is being administered. The limitation, which really harkens back to a lot of the things we had with COVID, is that we don't have a lot of it. So the vaccine has been really limited to people who have known exposures to monkeypox or are deemed to be at high risk for monkeypox exposures, which, because the majority of the cases described thus far have really been in men who have sex with men, that has been one of the populations in where preemptive vaccination has been offered based on availability and based on risks deemed between that patient and their personal, healthcare provider. For our healthcare workers who have exposure, that is another group of people who have received the vaccine, but we don't have enough for broad-based vaccination yet to the general public. So again, people with a known close exposure, regardless of any other sexual orientation or community connections in which there may be some different risk modifiers. If you are contacted regarding a potential exposure, vaccination may be something that you're offered. And then again, looking at where the highest risk is. Now, as we see more cases evolve, that risk panel in the community of who may be eligible for vaccines is going to continue to widen well beyond the populations that have been vaccinated to date. But with the limitations we have in place, that is a more difficult vaccine status to sort through what those tiers of exposure will look like and it will be more available to. Ultimately, I think the goal from a national level is to make it widely available to try to kind of halt the continued outbreak of this infection.
If you could look into your infectious diseases crystal ball of science, with this outbreak, has it peaked? Do you think it will get worse? What's the scenario right now?
In all reality, I don't think we've seen the peak. I think we're going to see more cases. I think the fact that it is a long incubation period, that people can have just a couple lesions and may not even be aware of it right away before they're at risk of spreading it to other people, because it is not something most people are used to looking for or evaluating on themselves, or even sometimes in clinic where healthcare providers have not seen this before. I think we have risks of missing cases and having continued exposures, and people are infectious for several weeks. And so when we look at all of those pieces together and not having a vaccine that we can provide broad-based immunity for, I think we're going to continue to see cases. I think we are all concerned that this will become something that moves into more of an endemic realm, where if we can't stop these outbreaks soon, globally, we're just going to have the kind of the low levels of monkeypox that are going to perpetually be seen in patients over time, and we may not be able to stop this in full from becoming something that is endemic and a risk that just exists amongst people.
A topic you and I are certainly interested in talking about is COVID. Just sending the kids back to school now, and once again, plenty of cases in the community. What's the scenario right now as far as the transmission rate?
So over the last few weeks, we've actually seen decreased numbers of confirmed cases reported. Now, there is some variation there because a lot of people use home tests and don't necessarily go to their county website, like going to Douglas County and reporting their home test as positive. So certainly what we see on our dashboards is an underestimate of the community rates. But we have seen that, the majority of people have been vaccinated, if not had at least one case of COVID to date in most communities. And so I do think that we have a little bit higher level of immunity from all of those pieces together. And we're certainly not seeing people become as ill. Now, that being said, for people who had infections, 6 months to more in the past, we are seeing patients being reinfected, right, with the variants that have changed over time. And so I think as we move into this school time again and having people gathering indoors where there are people who have not had it recently, who there are kids who are not vaccinated, there are staff who, very well may not be vaccinated. There is certainly a risk that we're going to see some increased transmission in these settings. And, thankfully, again, we're not seeing as severe of disease, but it does not preclude, longer term risks from long COVID or other symptoms that can evolve from that perspective. So in some ways, I think time will tell how much the burden will change once we're in school for a few weeks, but definitely something we're going to be keeping an eye on and watching to see if we start to see an uptrend now that the kids are all back in school.
What are the variants that are going around now, and are there any new or different symptoms that are coming with these?
So the vast majority of our current cases are BA5. So over 70% of the cases. We've actually seen a little uptick more recently and seeing a little more of the original Omicron variant also kind of coming through. And together those two are getting us to 85+%. So any other variants are very, very low level, not necessarily picking up steam, if you will, as far as their spread when we look at the most recent data. Symptoms, honestly, because we're not seeing that severe level of disease with hospitalizations and ICU level stays like we saw before, we're really seeing very mild, infections, things that people are attributing to potential allergies or, a summer cold that feels fairly mild to them, but actually may in fact be COVID. And then we've had a fair number of patients who have been asymptomatic at the time of diagnosis. So again, it does seem to be a milder form. Of course, there are some patients who still get more ill, especially those with higher risk underlying medical conditions or immune compromise that do end up in the hospital. But I think for most of the immune competent people, it does seem to be much milder, much more like, again, symptoms more like a common cold, which really should then, encourage people, think about getting tested. Go into your clinic, use a home test, order the free tests that have been available, but try to see if you can get a test just so that you're aware and can try to avoid spreading it to other people inadvertently.
I think those of us who have kids or have had symptoms ourselves, like we actually have preferred bands of home tests by now because it's something we're so used to.
Yeah.
With the variants that we've seen, it seems like they keep getting more mild. Will that continue to be the case, or could something completely different still be down the pipe?
So it's a great question. And I think, we have seen that transition to milder disease. And part of that is the utilization of vaccines and the seroprevalence in the community of people who've been infected, particularly most recently with these Omicron waves that really just had massive spikes of people getting infected. Could there be a virus that evolves that has more immune evasion, that could be more severe? That can happen. And these viruses, as we've seen, have the ability to have some changes, genetically and in their antigens to really become potentially more severe. If there was a major change in the virus genetically, it is possible that we could see a more severe version of a COVID-19 infection arise. And I think, as we think about that historically, that's very much like thinking about influenza, right? Where sometimes we do see a strain of influenza that is particularly bad, that makes more people sick with more severe disease than we had seen, for several years. That can certainly happen with this virus also. The question of, can we predict it? I don't think we can predict it. Are we concerned about it? Do we think about it? Absolutely.
Something that's new since the last time we had one of these conversations is the Novavax vaccine. What makes this one different, and who is it best for?
Yeah, so the Novavax vaccine is one that we've been waiting for a really long time, right? And it's different from the Pfizer and Moderna, which were the mRNA vaccines, or the J&J Janssen vaccine, which was this viral vector vaccine, because it's really using proteins from the virus. So it is not having that same kind of genetic concern that people had about integrating into DNA, which again, we know did not happen. But it's really more of the traditional vaccine technology that we've used for many vaccines that have been on the market for years. We think commonly about the pneumonia vaccine, very similar style of vaccine, no live virus used in it at all, no mRNA used in it at all, just really trying to use, pieces of protein from the virus to get, and particularly that spike protein, to try to get our immune system to recognize that one piece of it as being foreign and something our immune system should respond to. It is approved by EUA for those who are 12 and up. So for younger kids, this is not yet an option. It, is available for adults. It is a 2-shot series, much like many of the others we've seen before. And there were a lot of people that really had concerns about the mRNA technology and how that technology came into fruition, the fact that it was newer and people were hesitant to use it. This is a great option for anybody who's not been vaccinated or anybody who had prior concerns about the technology or the mRNA. This really, again, is a technology that historically was being used for long periods of time for COVID vaccines.
I know you're busy, so I have exactly 2 more questions. The next one regarding boosters. Who should be getting boosters right now?
So I think, one, I'm going to really reiterate, please talk to your primary care providers about your eligibility for boosters. You can look at the CDC website also for up-to-date information. So anybody who finished their initial primary series who's immunocompetent, there wasn't a recommended booster for those people at least 6 months after their initial series was ended, although there's been some fluctuations in timelines with that in general. There was additional recommendations that came up from the CDC to do yet another booster for those who are 50 and older. So if you are in that category and you have not had boosters, you absolutely want to be considering that and looking towards getting a potential booster, especially as we think about entering this fall and winter season where more people are coming indoors and where there still may be some increased risk of seeing a wave of COVID through our communities. Kids can get boosters for those, again, depending on when they got their primary series, but there are not multiple boosters approved for kids yet. There's really only that single booster. The immunocompromised patients are different. And this is where, if you have any questions about if you're immunocompromised or not, based on medical condition or medications you take, I would really urge people to review the CDC website and talk to their primary care providers to be evaluated and understand that. But that vaccine series is different, in which the initial vaccine series, the primary series, as we call it, was really 3 vaccines. And then there was recommendations for up to 2 boosters, again, depending on timing of when the vaccine has been completed and whether you're eligible immediately for all of those, or whether or not you need to wait a period of time to get that kind of last booster. So there's a lot of variation on timing of boosters based on when you received your primary series, based on your age, and based on your immune status. So any questions at all, absolutely talk to your primary care providers, but know that everybody has the ability to get at least 1 recommended booster to date. Now, I know we were chatting a little bit offline earlier about the fact that there's a lot of discussion about, are we going to have another booster this fall come out? And is it going to be more specific to this Omicron variant? Is it going to be updated in that viral component? And there's a lot of discussion about it. We're hearing a lot from the pharmaceutical companies who are making the vaccines that they are coming out with these boosters, but if and when they're going to be available this fall and for whom, that is information I don't have yet myself. And so I think it's stuff that we are waiting to understand, and components that we're trying to know. Are we going to see those become available? Are they going to be available for everybody? If they do, how soon would that be? Those are pieces that we're still not sure of.
I mentioned this is the third year that we've sent kids back to the classroom with COVID going on, but this year almost looks more normal, like a normal school year, because a lot of the things that we were seeing to prevent transmission have gone away. We still have concerts going on. Mask wearing isn't really happening very frequently. In general, what's your advice for people when it comes to just keeping themselves and their families safe?
Yeah, so I think that you're right. People have tried to move back to what is normal. And I think there's probably some change. I don't know that we are ever going to go back to the pre-COVID full normal realms of life, in the fact that I think everybody has heightened awareness of the risk if someone is coughing and sneezing around you, of having infection, of needing good hand hygiene, about thinking about staying home if you're sick and making sure you don't have something that's contagious to other people. Mask use is still effective. And we absolutely still, use those in our hospital settings to prevent infection there. And really, it's become optional in the general community, but is never a bad option to consider. Okay. That's always going to provide some additional safety measures in indoor spaces, in crowded spaces. Now, I recognize that is a very unpopular statement to make, but it is a reality of the utility of them. Now, that being said, I recognize that most people are not going to step into wearing masks. So what else do we do? If you have symptoms, even if they're mild, think about getting tested. Think about knowing if you have COVID-19 that's active, so that you don't spread it to other people, whether it's in your household, whether it's, teammates on a team, colleagues at work, friends at school, or other people in your family or friend circle who may have more immunocompromised or other medical conditions that put them at higher risk. To really keep in mind great hand washing, hand hygiene. Those pieces are always going to be important for prevention of spread, especially in close contact. If someone is coughing and sneezing around you, yes, the risk becomes if you breathe it in, but you still can, get things on your hands, COVID-19 and otherwise. So maintaining those and trying to maintain adequate space when you can from other people. Avoid really highly crowded areas and keep an eye on the numbers. The higher the numbers rise with positive cases, the higher the risk is of getting another infection. And then we've talked about all those pieces of boosters, right? And trying to stay safe. And as we enter this fall and winter virus season, one of the things to remember is we are seeing some of those other viruses back again now that not everybody's masked. So thinking about, do you have influenza? Are we going to see the rise of influenza significantly this fall again? And if other countries such as Australia are an idea for us, we may very well see a lot more of that coming back. So that's going to be very hard to tell the difference between that and COVID-19, and both are contagious to others. So thinking about getting influenza vaccines for the year, again, understanding what you have, space, hand hygiene, all the things that we've talked about that are just good precautions at all times. And if you can, while we still have wonderful weather, enjoy time with other people outdoors. The risk is so much lower in outdoor settings that is also another fantastic option to use as long as we can before winter strikes.
So much good advice, and we covered so many topics today. Thank you so much for your time, as always. Thanks to those of you who have been watching. You can submit a question anytime at nebraskamed.com. We take those questions into consideration. That's how we compiled our list today. Dr. Cawcutt, thank you very much, and have a great afternoon. Okay.
Absolutely. Thank you.
All right. Thanks all of you for watching. Goodbye.